يسعدنا تواجد حضراتكم في الاجتماع الندوة الشهرية بتاعتنا. طبعا دكتور جورج هو صاحب الدعوة وصاحب البيت وبيشرفنا بوجوده ونستفيد منه دايما. أنا سمير أبو المجد، النايب الجونيور بتاع الدكتورة سعاد، وهي تشايلد سايكايترست وأنا فيكشن ميديسن، ولكن هنستفيد من الدكتور جورج النهارده. يسعدني تواجده معانا. طبعا كلكم عارفين بروفيسور جورج تاودرز، بروفيسور ليازون سايكياتري اند ديمنشيا، أسن ميديكال سكول من أسن يونيفرسيتي. طبعا هو البروفيسور الزائر عندنا adjunct بروفيسور سايكياتري من كايرو يونيفرسيتي. هو الانفنتور of the project to rate the rapid assessment interface discharge in UK. وده بيطبق في اليو كي اعتقد في كل الامننت ميديكال سكول لليو كي، وان شاء الله نطبقه في مصر. هو الكوردينيتور MOU between Cairo University and Aston University. شرفنا تواجده معانا. المحاضرة لا تزيد عن 15 كده. اتفضل.
I'm really honored to be here. ده شرف كبير ليا. أشكركم جدا على الدعوة الحلوة. مقابلة الدكتور سعاد، الدكتور محمد، الدكتور عبد الرحمن، الدكتور سمير، كلكم أساتذتنا وأنا تعلمت منكم كتير. وأكثر حاجة بتعلمها منكم الانثوزيازم والكوميتمنت. هقول لكم على حاجة غريبة، حاجتين بسرعة. أنا دلوقتي بروفيسور في أستون وبروفيسور زائر هنا. أنا كنت بروفيسور في وورك ميديكال سكول في تشستر. I had few professorial chairs, but the chair that really touched my heart when I got the title here with Cairo. That is my biggest honor. That is. وإحنا بنقول السلام الوطني. أنا بقالي 25 سنة مش عايش في مصر، بس وإحنا بنقول السلام الوطني I had all the emotions and I really remembered إن مصر مش وطن إحنا بنعيش فيه، لكن وطن بيعيش فينا. المصري بتاعنا كلنا. هنتكلم على liaison psychiatry، ومش هقول لكم liaison يعني إيه أصل الكلمة، خليكم أنتوا تدوروا عليها. الكلمة أصلا جت من فين من زمان. لو دورت على أصلها you will not find it. Not a very nice word. But anyway, liaison psychiatry is the bridge between psychiatry and all the medical specialties, and I'm going to show you this now. I just want to see people in the room. Who is from psychiatry? Who is from geriatric medicine? Very good. Who is from medicine? Very good. Okay. Surgery? Excellent. Gynecology, obstetrics, orthopedics, cardiology. I'll show respiratory medicine, renal medicine. I'll show you what we can do, because liaison psychiatry is really, really brilliant. Right. I was talking with Dr. Maha earlier on, and the population is growing older. Even in Egypt here, people are living longer. I know Dr. Saad, child psychiatrist, and master of Benekhalif, and then children here. But the old age is growing and the population is growing. And to be honest, I think the future is for old age. Because we'll have a big population, and this big population don't have people who are trained to deal with their problems. And it needs a lot of skills and a lot of art. So in the UK, the average lifespan for a woman is 83 and man 79. But what I want to share with you very quickly, a baby born in the UK in 2000, a baby born in the UK and lived in the UK has a 50-50 chance to live to the year to be 100. When they did the NHS in the UK, they didn't expect the people to live that long. Now, people born, baby born in 2011 has more chances to live in 100 more than people when the NHS was there. So people are growing older. But if you look, and you helped me with the Asr Aini, Just think of the numbers in your head. In the UK, we have every year about 8 million admissions. 16 million admissions every year. 8 million of them are with older people. Now, where are those older people in the UK hospitals? In the Department of Geriatric Medicine? No. Everywhere. In orthopedics, in cardiology, in endocrinology, in gynecology, and every part. And this is what I want to think, that psychiatry should spread everywhere. If you think about them, 70% of people referred to old age place in psychiatry never had any psychiatric intervention before. The first time they were picked up, that's when they were coming to us. Osama told me this before. How big of Asra, how many patients you have? Inpatients. 5,000. Just to keep the 5,000 number in your head, 27% will have dementia. 50% will have cognitive impairment. 25% have delirium. And 25% will have depression. Can you imagine the numbers? Who is looking after them? That should be you. Right. I'll skip this because I want to show you something else. What's happening with the health of older people? You find about 25% of men and women reported they had bad health above the age of 65. Even with Dr. Samir Abul-Magdi with us, alcohol problems in the UK is more in older people after retirement, and there are new people coming in. So in the hospital, because we don't think about older people, we used a screening tool for alcohol called FAST. This is FAST is for anybody. And if you do the FAST screening tool, 1% of older people coming to the hospital will have addiction problem. But if you don't use the FAST screening tool, and you use the MAST-G screening tool, which is specific for older people, the 1% becomes 18%. So if we don't focus on older people, something specific for them, we'll miss a lot of things. Again, back to the Asr al-Aini. Obviously, you want your patients to come to the hospital, leave the hospital in a better way, healthier, stronger, and you don't stay for long. But if your patient has one of these 3 Ds, dementia, depression, or delirium, the length of stay will be longer, the quality of care will be poorer, they will have more falls, and can I surprise you, they will have more infections in the hospital and more mortality because they have one of those 3 things. Right. With my friends in the room from geriatric medicine in general as well, we did a study in Birmingham. This is a study I've done. We looked into people coming to the assessment unit. In England, when patients come to the hospital, they come to assessment unit first, and then we discharge them or we admit them. We looked at the people coming into the acute hospital assessment unit, and we looked for anybody that came with either dementia or depression or delirium. Out of 1,000 patients, we found 10% of older people coming to the acute assessment unit had any of these diagnoses, any combination of them. And this is unbelievable, this is very low. So we repeated the work prospectively, and I really hope with Dr. Noha leading the old age, and with Dr. Maha and with the people here interested, we can repeat this. Because what we did a prospective study. Every elderly patient coming to the assessment unit, we screened them ourselves for depression or delirium or dementia or combination. And the 10% becomes 70%. What I want you to think about, it's not about giving a diagnosis, but the difference between 70% and 10%, these are real patients who leave the hospital without the care they should have had. And that improves their quality of life. So this is what I want to think about. Why older people come to the hospital then? And I'll give you some surprise. And please interrupt me if it's different from Cairo. So 14% comes after a fall. And I was talking earlier on with Dr. Maha and Dr. Maha about orthogeriatrics. So 14% because of a fall, 12% hip replacement, 9% UTI, water infection, chest infection 7%, stroke 7%. What happens to them? Look what we do to them. People who came from care home, 33% of them came from care home. But the people who went to care home from the hospital to a care home became 42%. So what did we do? Rather than helping them to go back to their homes, we are shipping them to care homes. If people came from their own home, 60% came from own home, only half of them went back to their own home. Why is that? I'm going to blame ourselves. I'm going to say because we did not give them that joint care which looked after their delirium, depression, and dementia. And the care they get on the wards. This slide shows something interesting. If you just look at the first line about the care home, the longer the patient stays in the hospital, the less likely they are going back to their home. The longer they stay in the hospital, the more likely they are going to end up in a care home. Why they end up in a care home? They lose their skills. They lose their support. So do they become better or worse? Worse. Right. Talk about psychiatry in general, rather than old age psychiatry. So people who come to the emergency department for psychiatric manifestations, they usually come for self-harm, they feel despair, they feel all these kind of things. They can't manage their thoughts. And they don't know what to do. But look at this one. Persons with a psychiatric diagnosis, any psychiatric diagnosis, presented to the emergency department 5 times more often than persons without psychiatric manifestations. Again, with أساتذتنا معانا في الأوضة, I really would like to see that happening here. We do that kind of research. حال الناس في مصر اللي عندهم psychiatric disorders, they come to the emergency with physical complaints more than people without psychiatric disorders. We don't know, but it's interesting. We can look into that. Again, I don't know about Cairo as such, but love to work jointly with you. In the UK, we try really our best, and people get, the budget is huge, and the A&E working all the time, and there are targets, and every patient has to be seen within 4 hours, sorted, everything. But psychiatric patients coming to the ED, the emergency department, for any reason, I'm not talking about psychiatric reason, for any reason, they report that they were treated badly in the ED. Is that similar to what happens in Cairo? Again, this is something we need to know. Right. So if people are treated badly in the ED because they have psychiatric manifestations, why they come to the emergency department? They feel desperate, they feel nobody is listening to them, they feel they are in the abyss, they are in hell, and they want some help. So they accept to come to the ED. Okay. Again, liaison psychiatry with the emergency department. And I just really want to see the same things happening here. When do people come to the ED? More in the weekend or more during the weekdays? In England, they come more in the weekdays rather than the weekend. Maybe because of the weekend they are enjoying themselves, they don't want to come to the hospital. But people who come with the weekend referrals, they are slightly less likely to come to an admission. Again, we can do that work together in the emergency department, see how many people come, when they come, what happens to them, all that work we can do together. Again, I was talking with Dr. Maha, and I was talking with Dr. Maha about joint work. And because of the time, I'm not going to go through this report, but please, just go and see this report on the internet. It's a UK publication, it's called Treat as One. And you will enjoy it. It's about 30 pages, it's fantastic. Good summary. But it says 2 things. Treat as one means what? Treat physical and mental illness as one thing, but also treat people with psychiatric disorder and physical disorders in the same way. In the same way. Called parity extremes. What is happening to mental health crisis? People coming to the ED in crisis or seeking help at the time of crisis. We put a lot of support to people, and I see the fantastic work around here. Do you think mental health crisis is going up or down? You see the curve? It's been going up. This is real data from Birmingham. It's going up and predicted to even go further up. What's the solution? Dr. Abdurrahman can tell about technology. I'll show you something with the technology. And I'm sure the young people in the room will be better than me, so shout at me if I get things wrong. Right. I'll just show you what we have in Birmingham. We have 5 liaison teams. I'll show you each team what it consists of. Each team costs about £1 million, sterling pounds. And then we have place of safety for people to come. We have a street triage, which I'm not going to talk about today. But again, another idea. In Birmingham, if a patient gets too excited, too unwell in the community, they used to get the police arrested them, put them in the police station for a night or 2, and then a psychiatrist goes to see them after a couple of days, and the social worker, and they are in the police station. We never do that anymore. If a patient is unwell in the community and they call the police goes out with the psychiatric nurse and the paramedic. The paramedic takes care of the physical health, do ECG, look at the wounds. The psychiatric nurse takes care of the psychiatric part, and the police keeps the peace. Also, we have ECT, we have helpline, we go and visit people in their homes, we have a bed management team, we have 50 sites for psychiatry. We have Samaritans, which I think you have here. Is Samaritan here? For people with suicidal thoughts can talk to them online. We have charities, we have social services, we have GPs all the time. Is that good for mental health? In the middle, the patient is absolutely confused, doesn't know what to do, and the crisis is going up all the time. What can we do then? Right. So, Dr. Samir, this is the RAID, the Rapid Assessment Interface Charge. We called it RAID till recently. Somebody got the trademark for RAID and sued us in the court and take the trademark from us. So we lost to that, and that is still giving me pain. But what we do, if you want to develop liaison psychiatry, which I'm sure you can do it far better than us, and I'm sure we can work together to develop